It's 6 p.m., so we start with this webinar that make you the possibility to know this device that's magnetic mallet. I'm Dr. Luca Boschini. I'm from Rimini. Rimini is a nice seaside town in Italy on the Adriatic Sea. And my occupation is dentist, of course, but in particular in oral surgery. Today, I'm here to explain to you about the use of magnetic mallet. That is a very fine device because it's an automatic hammer that allows a lot of surgery and make it very, very simple. So let's start with the first case, with the first video about an extraction. Extraction, I think, is one of the main surgery that you can do with this device. You can use some tips of this device as a shield. You can use this like an elevator when you have a situation like that of the video in which you have not a grip to extract the fractured tooth. In this case, we have a residual root and to extract it, but if you use some bars, you can take out a lot of bone. In this case, using this kind of elevator associated to the shot of the magnetic mallet, you can extract the tooth in a very conservative way. You can conserve the socket, and this is very important because you can save bone in order to place, for example, an implant. These are some elevators. We have 5 tips for extraction. This is the tip number 2. You can put the tip between the space of the periodontal ligament, and you can use it also as an elevator, but you can associate to the elevator the shot of the mallet. In this case, you can go on elevating the fragment. You can see the tip is more or less like a chisel, and with the handpiece of the magnetic mallet, you can give a shot to these tips in order to remove the fragmented tooth. Okay, you can see the subsequent shot, and associated to the shot, you can elevate the root, like in this case. So with this device, you can have very conservative extraction and you can save a lot of bone. In this case, there was also a granuloma under the tooth, and you can see that we complete the extraction with the remotion of the periapical lesion. Before, with this excavator, you can see begun removing the lesion, but I want to underline the conservation of the socket. Very, very, very important if you need to place an implant after the extraction. Okay, you can see the lesion with the microscope. Okay. And now, with an excavator, we complete the remotion of the granuloma. If you have any question, I suggest to wait the end of the webinar, and I'd ask to you to write in English, please. Okay, in a few minutes we will complete the remotion of the lesion. Okay. And now you can see the granuloma exiting from the socket. Perfect. So we can go on and pass to the next video. Seb, you can go to the other video. Okay. This is a video about the implant placement using this kind of device. One of the advantages of this device is that you can use the tip without. Okay, after elevated flap, you can begin using a sequence of ostetome more or less as with bar. So there are subsequent measure of and diameter of ostetome. We start with the first one, the second one, and please look at this point. You can see a contouring of the bone. One of the other advantages in using this kind of technique is that you don't remove bone, but you move the bone. So we are moving the bone in buccal direction, recontouring the bone. We go on with the second diameter. Look at this position. Again, the next ostetome. And now we finished placement with the implant placement. Look at the recontouring of the bone. And this kind of solution is foundable with the use of a device that allows to move bone and not to remove it. Of course, you have a great primary stability of the implant. Perfect. And finally, we can place the healing abutment. This is wonderful, I think. Okay. This is a practical example of implant placement when you have healed bone. But you can use this device also to prepare a site for a post-extraction implant, post-extractive implant. So we can start with the next video in which you can see that we prepare with this kind of ostetome the site after the extraction of a molar, of the first molar. And we are preparing the site using the septum. So we point in the middle of the septum, and we start to prepare with this kind of osteotome. These osteotomes are the black ruby that are very useful to prepare the site for implant. And with this kind of osteotome, you can expand the bone, so you can have a preparation without remove other bone. When you have a tooth extraction, you have a very poor quantity of bone, so it's important to not remove other bone, and with this kind of device you can expand this bone and don't remove it. There are a sequence of 5 diameter of black ruby. We started to the first one, and you can go on with the second, the third one, the third, and this is the black ruby number 5. Okay, after the last black ruby, we can place the implant. And the wonderful things is, first of all, that we add the best visibility because we had not irrigation. And we had a very important expansion of the bone, so that the postoperative X-ray seems like an healed X-ray. We finalize the insertion of the implant. The stability was great, so we had the possibility to place an healing abutment. This is the situation after the implant placement. With collagen, we fill the socket and we place the healing abutment. Other collagen for the part of the socket that remained empty. Okay, and the surgery is finished. The video was more or less in real time, so the placement of an implant with this kind of device is getting in a few minutes. And this is the post-operative X-ray. Maybe you can believe that is the X-ray taken after the healing of the implant, but this is the post-operative X-ray. We have a great condensation of the bone that allow a great primary stability, also in a situation like the situation of the extraction of a third molar, a first molar, upper molar that had 3 different roots. Okay, now I'm showing the last video. This video has a professional voiceover, so I don't will speak on this video. Okay, I'm uploading it. Seb, can you remove one of the other? Okay, I did it. Perfect. I was saying that I was telling you that the video is about the crestal sinus lifting. So you can see the association of the preparation of the site of the implant, but associated to the elevation of the membrane. So let's go.
Today, we will examine a case of implant placement on a site with low bone height. From the CBCT, you can measure it as 7.4 millimeters. The other peculiarity of this case is that the sinus floor is not straight, so we'll have to do a slight crestal elevation to elevate mainly the distal part of the implant site. On the other hand, when we look at the cross-section, we see how the buccal bone surface is lacking. The reason is that there has already been a previous implant failure in this area. So while we have some crests on the palatine cortical, the vestibular cortical part is shallow or not existing at all. At this point, we have to do a sort of bone shaping, modifying the ridge to get a proper implant site. We start by doing the anesthesia, in this case 4% articaine, 1 to 100,000, and then we proceed to the incision using a scalpel. In this case, we make a crestal incision, but without any release because there is no need for it, and in fact, it can be helpful to have a little bit of periosteum on the vestibular cortical surface when doing a ridge expansion. We start to elevate the flap with a Pritchard. It will be enough to elevate the first millimeters and proceed palatally. Except for the first few millimeters, where there is a full thickness elevation, we leave the deeper part of the flap in place. At this point, we can start cleaning, doing a little bit of curettage on the area to clear it of any soft tissue residues. As we said earlier, there was already an implant failure in this area, so you can find some fibrous tissue residues even if it's been a while. Let's start with the mullet. In this case, we begin with a black ruby insert, number 1, which is very sharp and used to start tracing the way for the implant placement. In this case, I was looking for where to place the instrument, and let's start using the mullet. You see, I'm going more toward the palatine direction because the purpose is, by going in and by correcting the insertion axis, to distort the bone and bring it a little bit vestibular. So we go in with the tip toward the palatine direction, but as we get in, we correct the insertion axis by forcing it. We then move on to the next insert. This is a sequence of inserts precisely called black ruby, which replace burrs, so they have diameters of increasing size. You see, we always enter a little bit towards the palatine, but then, at every stroke of this instrument, we change the insertion axis. Gradually, with instrument number 3, you see that it goes in and starts to fracture the vestibular cortical a little bit, which is what we look for because we have to expand, deforming this insertion site to keep a little bit of bone also buccally.
Okay, I stop just a second this video because I want to underline this concept. When you use this kind of device, you can use the osteotome with a direction that you can change going down during the preparation, going down into the bone, in order to move some bone from a place to the place in that we need more bone. So in this case, I insert the tip from buccal to palatal side, but when I went down in the bone, I changed the direction in order to move bone from the palatal side to the buccal side, where the bone was less. Okay, let's go on.
We go in until we get to the sinus cortical area. You see that I've changed the power because now I'm in the sinus, so I must be able to break it. To do that, I often use another insert like this one, which is a flat tip, so I get an actual cortical block coming off by lifting the membrane. Instead, the black ruby inserts I used earlier have a rounded tip that makes it easier to slide inside the bone. However, when getting to the sinus, they cannot make an entire access cavity. They can lift the membrane a little, so I sometimes prefer to use other instruments.
Okay, I stop again the video because I want to underline another aspect. Black ruby, that is the instrument colored in black that you saw before, are useful for the side preparation because they have a round tip and they are less conical respect other kind of instrument. So they are useful for the side preparation, but there are a lot of insert of tip for the magnetic mallet. Some other tips as a flat point that are more useful in order to break the sinus floor. Okay, so in this case I use both the black ruby and the traditional osteotome in order to prepare the site, but in order also to break the membrane, or better, not the membrane, the sinus floor, the bone at the sinus floor, avoiding to break, of course, the membrane.
You see, in this case, with a smaller instrument, I check whether the sinus has been fractured, and I use a smaller tool to get inside without touching the walls of the site. In that case, testing, since the cortical has not been fractured yet, I gently go back to the flathead instrument to attempt the fracture. In these cases, it might be necessary to increase the power and check again. In this case, we actually give a few little taps to lift the membrane once the cortical is fractured. You see that now the instrument penetrates better without the impediment of the membrane, so the last few taps of the flathead instrument give me the perception of the fracture. You see, with the smaller instrument, I go back in to assess the tissue access cavity inside the sinus. I expect to feel some elasticity. If the membrane is intact, its elastic return gives me the perception that we elevated it without fracturing.
Okay, in this phase, I was testing the integrity of the membrane, and for doing that, I used the instrument with the small diameter, but of course with the rounded tip, and I tried to find an elastic response from the membrane.
In this case, we have inserted a little collagen that we push up with our standard insert. Basically, we place it to protect the membrane. And this is what we see, a deformation of the buccal bone and the prepared site.
Okay, I think this is very interesting. You can see that the expansion feature of this kind of instrument, you have a recontouring of the bone.
We start to insert the implant, and here we see a few bits of the buccal bone coming off, but it's not a big deal. We screw the implant in. I do it by hand to be as gentle as possible, and once the insertion is complete, we can remove it. And that's what we find. So, in a reasonably thin crest, we have managed to deform the bone and also lift the membrane a little. I add more collagen externally, facing the flap against the bone and covering the implant. This collagen had not been previously hydrated, so it tends to stick to the instruments, but it's not a big deal. To avoid this, hydrate it with some saline solution first. And now we are going to match the flaps to close the wound. I usually make a neck suture by inserting the needle in the mesial vestibular area to ensure that the flaps sit well above the ridge. It results in an internal X that looks like a double point that, as you can see, compacts the flap well above the bone crust. I do this to ensure that those two parts of collagen remain properly adherent and can secure even the tiny parts of the fractured buccal bone. Let's close the knot. This is a non-absorbable monofilament and polyamide suture. I prefer monofilament suture because they tend not to let the plaque stick, so they are always very clean. After a fast cleansing, the surgery is over. See how well the flap is being compacted above the wound. This is the post-operative image. On the X-ray we can see very little, but on the CT scan we can clearly recognize a bone portion that has been shifted, fractured and elevated, thus allowing the insertion of an implant with an appropriate length. Remember that we had only 7.4 or 7.2 millimeters in some spots. In this case, we could also insert a significantly higher and longer implant, precisely a 10 millimeters implant, and at the same time, we could also widen the ridge a little bit. I hope this has been useful to you. Magnetodynamic surgery doesn't allow us to do interventions other than what we can do with ordinary manual instrumentation, but it certainly simplifies procedures because, with this tool, in only one handpiece, we have mollet and osteotomes.
Okay, I want to stop the video in order to allow to show you these results, because we had the cortical bone of the sinus floor that was moved up. You can see was the line of the sinus floor before the implant placement, and now this is the new line. So we had an elevation of the sinus floor without with in a very simple way, with an instrument that allow to push up the bone, simplifying the procedure.
So with a large variety of tips, we can really do a lot of different interventions. I hope you enjoyed it, and see you next time. Bye everyone.
Okay. Perfect. So I finished the presentation with these 4 cases, and you feel free to ask me what you want about the magnetodynamic surgery. Have you any question? You can write your question in the comments on the right of your screen, please, in English. I wait for 1 or 2 minutes. What is the age of the tools? How many time can we use? Okay, my tools are the same from when I bought the device, so more or less 5 years. The only tools that had to be changed sometime is the tools that have the point, because sometimes the point has not more point, but all the other tools are very, very, very durable. The Genoa tips. Okay, yes. There are a lot of tips that are usable with the magnetic mallet. I show you only a few instruments, but there are a lot of different tips. There are also tips that are used for split crest, and between the insert for the split crest, there are also the Genoa. There are more or less like a can opener, and are very useful to make an incision in the bone when you have to split it. So are very, very, very useful. But there are a lot of instruments. So the better things is to have the occasion to follow a course in order to understand that you can use this kind of device in order to see all the tools available for the magnetic mallet. So if you want, I'm available in order to come in Arabia, in South Arabia, for many courses, and also other colleagues are available too. Yes, Lazy Tooth, you can write your question, don't worry. We are waiting for lazy tooth. Is there any possibility to cause fracture while giving a stroke by these tools? I think you mean a fracture of the bone, of the crestal bone. Maybe, of course, the tool of the magnetic mallet are the same of the traditional surgery. The difference is that you have in only one device both the mallet and the osteotome, and it's very, very comfortable for the fact that you can have a free hands, for example, in order to keep the flap. But the tools are the same, the surgery that you can perform are the same, and also the complications are the same. So you can have the fracture, of course, but you can manage it as the same way that you can manage the same complication in traditional surgery. Okay, the pain is the same. The question was how is the pain compared to the drill? The pain is the same. The difference is that when you use the magnetic mallet, the patient feel the shot, but are very, very fast, this shot. So you have just a few moments in which the patient can be frightened, but you can go on because there is not so problematic for the patient. Is very, very less problematic than the traditional instrument with the handle mallet. Other question? Lazy tooth is lost, I think. I don't see your question. So, okay. Is it used with all forms of tapered and parallel implants? So there are different osteotome with different features. But with all these kind of design of the osteotome, you can use more or less every kind of implant. So that is not a problem. Of course, the black ruby have a shape that is more similar to the best, to the major part of implant design. But I'm sure that with at least one of the osteotome, you have a comparison between the osteotome shape and the implant shape. For the extraction, why should not do inside the tooth? Why cannot this machine for D1? Okay, so I reply before to this question. I think this device is very useful for bone D4 and D3. You can also use this device in bone D1 or D2, but it's very traumatic for the patient. If you have a D1 bone, I think it's better to use bars. And I don't understand the question. For extraction, why should not do inside of the tooth? I don't know what do you mean. What? Of course, for the extraction, we have some tips. These tips are some chisels, so you can go in the interface between the root and the bone in the periodontal ligament space. And with the shot of the device, you can go down in the interface. With the extraction point number 1, you can do a syndesmotomy. But with the extraction point number 2, you can try to have a movement in order to use the point, the tool, more or less like an elevator. So you can go down with the shot, and rotating the tool, you can have an elevation of the fragmented root. Okay, do you recommend using the maximum speed of the device? Absolutely not. I think you have to start with the power number 1 or number 2, and I use the number 3 or 4 only for 1 or 2 shots in particular situation. For example, I prepare the site implant in crestal sinus lifting under the sinus floor. When I want to break the bone of the sinus floor, I change the point. I use an osteotome with a flat or a concave point, and then I go the shot in order to break the sinus floor. In this moment, sometime I use a power like 3 or 4, but only in this moment. Okay, other question? I think the better thing in order to learn about this device is to have this device and study for a trial, or to follow a course in order to touch the device and to try the device with all the osteotome and the tools available for this device. Other question? Okay. I think the questions are finished. So the webinar is finished too. Greeting from Italy, and see you next time. Bye bye.